Thank you so much for coming to CPS Lectures 141. Hi, everyone. We're so excited to see you here. This is going to be incredible this evening in particular. My name is Kelly Close. For this evening's CPS lecture, I'm excited to introduce Dr. Sam McLean, who is the creator of a very innovative app, Heroes Health, that helps first responders and healthcare workers monitor and maintain their mental health while coping with the stresses of their jobs, which we know are so enormous right now. The app was created through a really impressive collaboration coordinated by Dr. McLean at the University of North Carolina, UNC, involving physician researchers from several other top universities and the technical expertise of volunteers from Google and X, Alphabet's Moonshot Factory. As research vice chair in the Department of Anesthesiology and attending physician in the Department of Emergency Medicine at UNC Chapel Hill, Dr. McLean studies trauma recovery and has developed preventive therapies to improve post-traumatic outcomes. In over 20 years of practice, he's worked not only to heal patients physically, but also to improve their quality of life following trauma. We can't help but to so admire his genuine desire to see patients thrive in every way possible. Dr. McLean got his undergraduate degree at Dartmouth College and his MD and MPH in general epidemiology at the University of Michigan. He then completed his internal medicine residency at Mass General and an emergency medicine residency at Boston Medical Center. So with the onset of the COVID-19 pandemic, Dr. McLean began work in a COVID-19 unit where in fact he contracted the virus, and subsequently 2 members of his family got it as well. They fortunately have all recovered. In the process, Dr. McLean really learned firsthand the new levels of stress and anxiety the coronavirus was creating for first responders and healthcare workers. And this led to the development of the Heroes Health initiative. Heroes Health is a free app that allows workers to track their mental health and access crucial resources. It allows users to send anonymous feedback to their employers, take brief surveys, and connect with therapists and experts. As the frontline workers face additional mental health consequences for their essential work in managing the pandemic, it couldn't be more necessary to help address some of this burden. And so we're so thrilled and honored to learn more about this project tonight. And there is more. We're going to be hearing from Dr. McLean this evening in conversation with one of the most monumental leaders in business today, whom we got to know last November at CPS Lectures number 126. Obi Felten gets moonshots ready for the real world. Obi knows firsthand about this project from her work at Alphabet's Google X. She really made it happen. She's been there for over a decade in increasingly senior positions. She's responsible, again, for taking innovative technology rooted in purpose into the real world. And we're so interested to get her perspective as well. And, kind of said another way, Obi's responsible for getting early stage X projects out of the lab and into the real world, or ensuring that they fail fast, which this one certainly didn't. So again, she's bringing so much perspective and expertise and valuable thinking on mental health in particular. So she serves on the board of Springer Nature. That's a global academic and educational publisher. She also serves on the Wellcome Trust Mental Health Priority Area, BFB Labs, that's a social tech startup designing digital interventions to improve youth mental health. And she's on the interim board setting up the Healthy Brains Global Initiative. She's also a trustee of Shift, that's a charity designing products to address social problems. You can tell this amazing woman has incredible influence. She got her BA in philosophy and psychology from Oxford, and she grew up in Berlin. As many of you know, and it's nice to see so many old friends here, as well as people who are new to CPS Lectures as well. This series serves to honor the memory of my dad, Cyril Patrick Shaughnessy, who died in 2002. These lectures are not only a tribute to his memory, but for nearly 20 years, this series has been a way to just spread his passion for sharing conversation and knowledge. The series is so close to my heart, and I'm so grateful to all of you for joining us tonight, and some of you many times previously. And always, I'm so grateful to my husband, John, for creating this series for me back all of those, it's almost decades ago. CPS Lectures is now a program of the diaTribe Foundation. That's a nonprofit we established 7 years ago to help improve the lives of people with diabetes and prediabetes and to advocate for action. And we've grown exponentially since 2013. If you know anyone with diabetes trying to prevent diabetes, send them to diaTribe.org, please. We now have almost 250,000 subscribers. That's grown from 6,000 subscribers back in 2000, in the late 2000s. And we've raised this year, up from 80,000, our first year as a nonprofit, which was 2013, we've raised almost 3 million this year. And that's a little less than we raised last year. And so we're looking to keep growth going. I want to give a huge thanks to the entire team for helping us reach this point, to everyone at the diaTribe Foundation. We couldn't have done it without your support, most especially Katie Brower, CPS Lectures organizer and manager extraordinaire. And a huge thank you to those of you who have donated to the diaTribe Foundation over the years. There's never any need to donate in order to attend CPS lectures, but we're so grateful for those who do. And if you think about making a donation, but haven't yet, now would be a great time to do so. A gift of any size. The diaTribe Foundation is working really hard right now on its year-end campaign to get to 227 donations from 227 more donations from individuals like you. That's between now and the last hour of December 31st. So making a gift is quick and easy at diaTribe.org/donate. And you know the drill. You can also help us spread the word. No gift is too large either. So before we start hearing from Dr. McLean and from Obi, I'd just first like to remind everyone, watch this lecture in presentation mode on Zoom. Before we begin, we're going to go around the virtual room. I know everyone who's watching this after won't have a chance to see this, but you can be thinking about your answer. You know, who is your personal hero? And in just a few words, what is the one act of mental health self-care that you've been doing during the pandemic? We'd love for everyone to think about that. And, you know, thanks for sharing, everyone. Now I'd love to turn it over to Dr. McLean and to Obi Felten to hear more about how we can help our healthcare heroes keep mentally healthy. Thank you so much, and turning it over to the two of you.
So nice to be back. In a virtual environment. It's not the same as your living room, but it's a good second best. So I am so thrilled and pleased to be here with Sam, who over the course of this project has become a friend. There was a point where, you know, we talked, I think, several times a week. It was such an intense period. But before we get into Heroes Health, which was the project we worked on together, I wanted to kick us off by talking a little bit about your academic research interests. So we first met because you run a huge study called Aurora that is about trauma in a broader sense. So tell us a little bit about that study and about its goals.
Yeah, so our general goal is to try to develop interventions, preventive interventions that we can give to someone right after a very stressful event to prevent them from developing post-traumatic stress or depressive symptoms or anxiety. The average emergency department, or say an emergency department that sees 100,000 people, sort of generates 5,000 to 10,000 new cases of post-traumatic stress, chronic pain, depression, anxiety a year. These post-traumatic conditions, neuropsychiatric conditions, cause just such a global burden of suffering. And it's kind of like, 150 years ago, say, if there was a wound, it was just considered, well, that had to pus out, it had to develop infection, and then some people are going to die, and then people who don't would have this healing stage. And we didn't even appreciate that, you actually didn't need the infection after the wound. And we're kind of in the same stage, unfortunately, in 2020, where we really don't have preventive interventions to prevent all of this brain health morbidity after stressful events. So my work is really focused largely on that issue sort of over the past 20 years. Aurora is a particular study that was really exciting and has been exciting to be involved with, because we have an opportunity to enroll thousands of trauma survivors around the US and do a lot of sort of sophisticated assessments, really largely focused on one of the fundamental problems in trying to improve or develop better treatments and better interventions so that for example, for a sexual assault survivor, that we can just as effectively prevent post-traumatic stress as we can for pregnancy or sexually transmitted disease. And that is that we really don't understand the biology of how these disorders develop very well. And so what Aurora does is brings lots of tech and lots of sort of latest omics type methods to try to get a better handle on what the heck causes these and how do they evolve.
You're being very humble. So Sam is running the study, and it's over 20 different institutions, right, across the nation that are actually involved in this. So you're kind of cat herding skills, in addition to being like the lead academic on it and developing the protocol, have been absolutely extraordinary on that study, because it's one of the largest scale studies. And also funded over $20 million now by the National Institute of Health, right? Like as you keep expanding it. So
right,
talk a bit more about the metrics. So because this is one of the areas that that I'm really interested in is how can we better measure mental health? And you're looking at lots of different metrics, right? So talk a little bit about like how you're doing that. And also the other thing that's interesting about the study is that you're measuring people not just once, but you're following them longitudinally over time.
Right. So one of the questions that was a core part of Aurora was the question of to what extent can different types of measures, different types of mental health measures effectively identify either differences between people, identify people who at a particular point in time have a lot of a particular mental health symptom, but do it passively without having to intrude upon them and ask them. And then also looking across time, are there measures that will tell us if someone is developing worsening pain or worsening sort of anxiety or arousal symptoms or different types of particular brain states. And we've been really excited to see that there are a lot of areas that really haven't been assessed that much that show a lot of promise in being able to do that. What's really exciting about that is that, as someone, all of us have different types of mental health symptoms over time, I think, in our lives. And we all know that when we're having a hard time, it can be hard to say, are you better this week or than you were a month ago? Like, who can answer that question? It can be very difficult. I mean, and so I think what we really need is ways for physicians and patients, and as you know so well, Obi, being such a leader in this space, but ways to be able to augment and help physicians or providers and patients to be able to better understand, is a particular treatment that they've saved and put on a new treatment or a new intervention, how can we get early indication of whether that's better or not? How can there be sort of constant communication and discussion between the provider and the patient regarding whether it's working and evidence of whether or not it's useful or not, or whether, hey, we need to try something else. So what we've been excited to see is, for example, we have a watch that we're fortunate that Verily has provided, one of Alphabet's arms. They're sort of one of their medical arms, and we've seen a lot of exciting signals coming out of the watch in that regard. Also, a lot of smartphone-based assessment measures. So, for example, by passively assessing a certain percentage of GPS, you can get a good sense of it correlates with various health measures, because when you're feeling better, you get out and about more. Or very interestingly, your keystrokes, how much you are typing and the way you type on your keyboard says a tremendous about your emotional state and your mental health state. So all of these things could be leveraged in the setting of a doctor-patient relationship to help me understand, say, as a patient, if I'm starting on a new depression treatment, how I'm doing.
Yeah, I thought one of the interesting signals you were looking at of the watch was actually sleep. So like when people are going to sleep, whether their sleep patterns are changing, whether they're waking up in the middle of the night. So for instance, PTSD, like that's a well-known symptom, right? So by using a sleep tracker, I'm wearing this ring, it's called the Aura. In the Aurora study, you're using the study watch from Verily, but these are much more able to accurately assess how we sleep than a person is able to do subjectively, because we sometimes wake up and we think we've slept fine when in fact our sleep's been very disrupted. And conversely, people say, I had a terrible night's sleep, and you look at their sleep data and it's actually fine. So I think that correlation between like depression, anxiety, and PTSD and sleep is one that's sort of attracting research interest, but it's relatively new. And I think it's a really interesting area.
Yeah, and I know, you've been really a thought leader in this space for a good while now. It's this sense that that you have, and that you've spoken eloquently about. I think, just that not seeing someone twice a year, 3 times a year, but getting more continuous feedback and information on what's going on.
Yeah, I mean, I'd say like all of this is the reason these are still academic studies is because it's early days, but the promise of using technology to measure some of these things that are difficult for humans to assess. And it's very true when someone comes to the doctor's office and they say, how have you slept on average over the last 2 weeks? Like, I can really remember how I slept last night,
Right.
let alone give an average. Like humans are not very good at computing averages. Whereas if you're recording that data with a wearable device, for instance, that's suddenly feasible. Great. Well, let's start talking about Heroes Health. So in addition to being an eminent trauma researcher, you're also still working in the hospital as an ER doctor. So what happened in March that prompted you to start the Heroes Health initiative?
It was really interesting in March in terms of the emergency department and just kind of one's day-to-day life as an emergency physician, because we all of a sudden had to think about not only, so where would patients with potential COVID symptoms be seen in the emergency department as a distinct place from folks without COVID symptoms or potential COVID symptoms, but even like, how do we make sure that there's no common footpath between those two people, or that there's no common shared airspace at any point as they approach the emergency department. So like every emergency department in the US, essentially, we put up a huge tent out front, and that became our initial triage area, and we broke up into a COVID unit and a non-COVID unit. And so I started to work these shifts in the COVID unit and was really struck by, even as I think as a coping mechanism, and as you see in many professions, and not necessarily for, in a very human way, understandable way, but not necessarily terribly useful way. People like to imagine, I think in emergency medicine, who work in the ER, that they've seen it all and things don't bother them. But even among that crowd, there was just a tremendous burden of stress working in the COVID unit, that with a lot of tears, a lot of struggles, a lot of very apparent struggles as people were moving out of their houses, living apart from their family, seeing a lot of tragedy, and just dealing with a lot. And I remember, for example, seeing a patient with a nurse, and the COVID test, we had thought they had COVID, but the COVID test came back. Or maybe I said, well, the COVID test came back, and so they have COVID, and the person was quite short of breath. We were taking care of him. But it was like the first time that she'd seen, and this was early in March, a patient that she knew that that had COVID. And when that just kind of hit home to her about sort of what that meant for her, and her in terms of her interacting with her family and her kids and stuff, she literally looked up at me and she was just like, I just need 5 minutes. And then and it was fine, because there was nothing, there was no, and she just walked out, and she just took off her stuff, and she just went and sat for like 5 minutes. And then she just kind of needed some time. Then she put all of her PPE back on and came back in. But like stuff like that doesn't happen. Like that didn't happen before. So I was really appreciating how much people were struggling. And I remember one time, particularly, I was seeing a nurse who started crying and was just crying by herself. And I thought, it's so crazy that we have all of these mental health folks at our wonderful medical center, just loads and loads of mental health professionals, and yet they're totally separate and divorced from and fragmented from people who are on the front lines, who are taking a shower, going to work, then taking a shower at the hospital, and then going home and taking another shower. And then, after 12 hours, maybe not seeing their family, maybe seeing their family, maybe living in a tent in their garage, maybe move their kids out. So it was like no one knew, and it was just like these totally different worlds. So that was really my interest in Heroes Health. And honestly, like we're talking about Heroes Health tonight is me being the person to do it, but it was really like a partnership between Obi and I. And Obi has it's really like, it's like you're talking to two people who tried to make something happen to see if it could be useful. And Obi was every bit as much of a person who helped to get off the ground.
Well, I remember the day you called me. So Sam called me from the hospital, and he said, I've had this idea of making an app that helps people measure their mental health, and then we'll connect them with mental health resources. And I need a technology partner. Will you help me build it? And I think I said yes instantly.
Immediately you said yes. Yeah, and immediately you were 100% all in. It went from, let me see if I can pitch this person who's obviously extremely talented and wonderful, but probably got a bajillion things going on, but I feel like it can't, with the worst thing you can say is a no. It made me like to then, I think within about 24 hours, then it was unusual. Can I keep up with Obi? That's just, then it became like, hey, could you possibly help me to do this? And then within like a day, you're like, holy crap, I've got to keep up with you to try to do this. So it was just absolutely fantastic. And not only Obi, but I saw Yuchi on earlier, and she'd be the first one to say she's an incredible leader, runs a fantastic team of incredibly talented people, and people like Yuchi, who I see here, were just immediately all in and insanely talented and put in so much time and effort.
So I think, so what happened was, like, we then put the word out and we asked the team at Google Cloud to help, and they immediately said yes, they would give some engineering resources. But then we also, I think by the end we had about 25 volunteer engineers from across Google. And I think what inspired all of us is we all felt really helpless, like the way you felt helpless in the year of no one even knew how to deal with COVID. And we felt the same. We were all starting to work from home. We were feeling very isolated. So really, we were grateful that you gave us this chance to do something that was very specifically contributing to COVID effort. Let's talk a little bit about like how you turned it into a project. So, because your initial idea was always like the measurement piece was at the core. Like, how can we help people measure? Why is that so important for frontline healthcare workers? To help them with the measurement.
I was looking for, I did feel like, Kelly talked earlier about opportunity and opportunities that COVID's created. And as many have said, COVID has helped us embrace our humanity, I think in ways that were long overdue. And I do think that in the emergency department, as in so many areas of the hospital, it's far more, there's far less barriers to talking about the struggles with sleep you're having, or the anxiety, or the depressive symptoms. And so the idea, the hope was that if we created a way for healthcare workers to be able to describe their symptoms, track their symptoms over time, but then be able to connect to this huge mental health resources that existed in many of the hospitals, and to provide the hospitals a way of being able to reach out to, for example, that nurse who was crying there and say, hey, I'm Debbie, I'm calling on behalf of the University of North Carolina. First of all, just thank you so much for what you're doing in the emergency department, because, or wherever, or to the environmental services worker, thank you so much for cleaning those rooms every day. If you didn't do that, we wouldn't be able to take care of those patients, and thanks so much. And then, oh, I saw you're not sleeping very well. And just created, honestly, an opportunity for like love within a community, because it's like, COVID has been just like an enemy, of love, and an enemy of support and fellowship. And so it's ultimately just about, you care for the people that you work with, but if you never see them and you can't talk to them, boy, that's just, just creates that heartbreaking isolation.
Yeah. So that actually brings me to my next question, which is, there was multiple people we had in mind when we were designing this product, right? So there's the healthcare worker themselves, there's the institution, and then there's the mental health, employee health groups that are serving the institution. So can you talk a little bit about like how you were thinking about like what's in it for each of them? Why would they use it? Like, how did you get the hospitals on board? Because you were then pitching it to hospital administrations. And what were some of the challenges that we discovered, for instance, around how do we handle privacy?
Right. Yeah. So I think that my hope was that, it is a difficult situation in terms of potential anxieties of the legal department of large bureaucracies regarding if people are going to be reporting their mental health symptoms, and if those mental health symptoms include asking about potential thoughts of self-harm. And if you say, well, we're going to have those reviewed within 24 hours, and then a lawyer will say, well, why not 12 hours? Well, what if someone had something happen and then they said, well, they filled out this survey, and they just can kind of go on, unfortunately, sort of off on a lot of concerns that I'm not sure are, well, I don't think are based around the greater good. But I did think that there was also a lot of, importantly, a lot of a sense of responsibility for organizations, healthcare organizations, and also a fear that the physicians and healthcare providers have been one of the areas, as you all know, that of workers within the economy that have been more burned out. And so you're kind of heading into this pandemic already with people feeling kind of frayed. And then what is this going to mean in terms of worker retention, long-term ability to keep and retain folks at the medical center? So both from just a economics perspective and also from a sense of responsibility, I hope that we could appeal to that and effectively get organizations to offer this program for their workers by offering it free, but saying, look, to use it, you need to provide a mental health resource, a mental health worker who can do the outreach, review these every day, and sort of be that sort of neighborhood pharmacist, but doing outreach to people.
Right. And one of the things we decided was to make the uptake easier, is we also made it open to any healthcare worker. So you can sign up either as an individual or you can sign up through the institution. But obviously for the institutions that joined Heroes Health, they will get that additional layer of local provision. So let's talk a little bit about that, about the adoption, right? So introducing a new product of any kind in healthcare is really hard. I actually looked up the literature. It takes on average 17 years from research to deployment. It must be like one of the longest innovation cycles in the world. So what has the uptake been like? You started a pilot at UNC Health, but you're now rolling out to hospitals across the nation. So tell us a little bit about that, and also like what you've learned, like how people are signing up, how they're using it, what kind of people are gravitating towards the app.
Yeah, so it is, it's so true. People tell me, or several people have asked me, why did you do this? A lot of people probably had the thought to do this. How was it that you did it? And I always tell them quite honestly, well, it's just because I know Obi Felten. I knew Obi Felten, and I asked her, and she said yes. So that was really the entire difference between me and the other schmooze out there who thought that this might be a useful thing to do.
We just did it faster, Sam. We did it in 4 months.
I know, it's crazy, and it has been for sure slower to get off the ground than and not for the tech purposes, but just for the bureaucratic, large anxieties about. And it is interesting, I have to say, as an ER doctor, some of the anxieties also can come from, not to a person, but from the mental health professionals as well, because it's different for them. There's a certain way of doing things that people are comfortable with. And I think that as an ER doctor, we do have an ER a little bit like, we just got to make it work. We got to figure out some way to make this work right now. And we're kind of used to a little bit more seat of the pants. And so the ER folks have been great in rolling it out. But what's great is that we've really finally, after far more delays than one would like, really met our inflection point where we're rolling out to, we'll be at more than a dozen places by the end of the month. So I'd say at UNC, for example, we have more than 800 users, and I don't know the exact numbers because of, again, the way that the sort of Byzantine type processes have worked. We don't have the mental health outcome data yet, but we're on our way to getting it. But I can tell you certainly that we've had dozens of people, probably upwards of 40, I would say, north of 40 that have expressed active thoughts of self-harm and that we've connected to mental health treatment and that are, in treatment and got connected to someone because of that. And then lots more folks who were having more mild or moderate symptoms, but were connected to a source of treatment or care of some kind. And at Cooper, hospital, Cooper University Health System, I think their experience has been similar to ours. I think that we've just started at the Jefferson system. It's a 10 hospital system based out of Philadelphia, but they've just rolled out last week to initially to the sort of COVID units at one hospital. Everyone is understandably anxious about the mental health outreach and not overwhelming a mental health worker who's not able to reach out to everyone who needs symptoms. So they want to all do it stepwise, which I respect. And then Indiana University. And what's been fun is to see we've been contacted by people that we didn't necessarily have foremost in our mind, although, because of the great planning and ideas. And I think this was, one thing that we talked about early on and you talked about early on was, allowing lots of different organizations the opportunity. So we've had, for example, there's an organization that runs nursing homes. And so they're putting this into place at about a dozen nursing homes that they own. We have emergency medical services work systems and EMS systems that are starting it. And we have also, it's been nice to see not just the haves, but the have-nots or the have-lesses, because hospitals are so, like everything else, hyper-segmented in our society. So we have like Appalachian Regional Hospital rolls out this week, which has been fun. So there's been a lot of different users around, but I would say that, cautiously optimistic that it's been a useful thing in the world, but I think we're going to have a lot more information from a lot more places over the next couple months, which I'm excited about.
That's great. I'm really glad that it's becoming inclusive, because that was like one of the things we talked about right in the beginnings. How do we not make this not just for the doctors and the nurses, but actually for everyone?
Yes, absolutely. Yeah, and it's going to be really interesting to see how it goes at all those different places. We're trying to build it up in terms of what's next. I would say that we had a couple different applications we've submitted basically around adding in digital interventions to folks who need it. So we, work with foundations that, like One Mind that have rankings of sort of the best mental health apps in different spaces and are able to find the best mental health apps and then and sort of rank them the lowest cost and best ones, and to link people up with those and then assess outcomes. That's something that we've been actively sort of working on and submitted a few proposals for funding that vary between, as you and I talked about, and you had some great ideas about this, maybe looking and seeing if there's an AI supported method that one could develop that would try to help figure out what would be the best intervention for the best person, to things that are more low cost in terms of implementing, to just say, hey, let's get this group therapy option set up, or a CBT option set up through the app. So those are things that we've been working on.
Okay, great. Well, I'm seeing lots of questions starting to roll in. So let's start with that. And Kelly is going to help moderate this as well. But I thought, Amy, you asked a couple of good questions that are kind of specific to the app around the data sharing and what kind of data flows into the app. So do you want to ask those directly to Sam?
Oh, I'd love to. Thank you. I'm just wondering, do you find that people are more willing to report symptoms because they think the data is being aggregated? Or do you think it's just like a lifeline? Like if I report these, someone might catch me before I go over the cliff.
We are very careful to say that that the data is treated just like information in one's medical record, and that it goes solely to a mental health worker or team at an institution, and so that the individual will be sharing that the responses that they provide only in a targeted fashion to that mental health worker or team, and of course it would never go to their boss or anyone that they work with, and that's super important. But I have been surprised that the vast majority of people who sign up for the app do choose to share their information, because it is an opt-in, and then we regularly ask people, we ask them, and when they on initial sign up, if they're willing to share their survey information, and then subsequently thereafter. And the great majority of people who choose to use the app also choose to share their information, which has been great to see.
Mm-hmm. And is it all questionnaire based, or are you using wearables at all?
No, so that's a great question. So this was meant to be really simple in terms of just to get it up and running quickly. So it's really a 5-minute survey. that is can expand it based on sort of the screening questions to perhaps a 10-minute survey, but still brief, and that really focuses on just a few core items: sleep, stress, anxiety, depressive symptoms, and really how mental health is affecting your function, and really targets those, and then tries to link people up to support.
Right. All the correlated stuff.
Yeah. But
Thank
Amy,
you.
so wearables is, it'd be possible to add them in. It just one thing where we were making these trade-offs between getting the app out into the world as fast as possible versus keep working on it for longer. So it's kind of like, I sort of look at it as a beta version, that the first was really a pilot that we tried to get up and running, because the feedback that we're getting from hospitals was going to be more valuable than us trying to guess it, especially in the COVID environment where everything changes all the time. But I think adding something in like some, like you have in the Aurora study with adding in some wearables would be interesting. We also got some when we did user interviews, they said things like, for instance, they can't wear a ring like this because of PPE, right? So you could wear the wearable overnight. So we would still, for instance, get the sleep data, which would be really valuable, but you wouldn't be able to wear it all the time in that environment. Great. Kelly, I'm going to hand it over to you to pick up some of these questions. And I think you probably have you always have great questions yourself. So feel free to also ask your own.
Well, one that I'm wondering about the most, and then I'm going to hand it over to Ellen to start and Kimberly next, and then we'll go to others in the line. But I'm just curious about shame associated with like stress and anxiety, and how have you found that? Because I would have thought like working with Alphabet, it would be great, they're like just what a partner and what a company to be like, so let's address this. But I'm kind of curious about, I don't know, like maybe different people in the hospital or the boards, or like has anyone's boss been worried who even doesn't know? But yeah, just if you can talk about shame more broadly, because I think it's getting much better, but it's not there yet, is it?
Yeah, I agree. I think it is getting better. We still have a ways to go, but I do think that particularly when numbers are going up, it's a very different thing when you read about cases going up in an area. The lives of the healthcare workers in that area are changing dramatically. It's one thing to have, a COVID rate that's just kind of percolating along. And do you see COVID patients in the COVID unit? Yeah, you do. But it's a different thing when the numbers go really up in an area, because more and more COVID workers start going out. And so the ones that aren't out because they're in quarantine or they're sick or whatever, then are working way more. Then people start, if you see like 3 COVID patients in your day and you have PPE, and you're doing it, you may not isolate from your family. If you see 40 COVID patients in a day and you're constantly taking COVID, PPE on and off and on and off, and people are coughing on you all day, you're probably not going home to your family anymore. You're probably separating yourself somehow. So when that stuff starts happening, everybody is in a hard place, and it becomes a really human space. It's people talk about stuff that they would not have spoken about before. And I don't mean to sound too, I'm not saying everybody, but it is very different in terms of the acceptability of mental health symptoms.
Well, I hope it's actually probably changing how people think about mental health symptoms more broadly also.
I hope so. Yeah, I hope so. I had a chief wellness officer ask me in one of the institutions that I actually ended up signing up with us, but they said, I was talking to my CEO, and they're like, why? And she was advocating for herself, but she said, I was talking to my CEO, and he was like, why are we in the healthcare business for these workers? Like other people in town, they don't run. Like, why are we in this? And I said, because going to work can kill them. Just going to work. So, that's kind of like throw them a bone, and there's many answers to that question, right? But I was just for the C-suite, like saying, well, you are asking them to potentially kill themselves. So I think it's reasonable to offer them a little mental health support through a hotline. And they did, they signed up. So
So many parallels then with
Yeah.
teachers and with so many others.
100%, and in no way, and heaven knows, in no way is this exclusive to so many people are doing so much, and I absolutely.
Yeah.
Well, yeah, and people will be really interested in hearing about other applications, but Ellen, over to you, and it's so nice to see you.
Yeah, no, amazing work you're doing. It's really, really impressive. Can you share a little bit more about the metrics you're using and or key, assessment questions? Are they standard instruments like a PHQ-9 or?
Yeah, it's a great question. So we tried to pick really standard, tried and true measures like the PHQ-9 that you mentioned, because we felt like our end user were ultimately going to be social workers, psychologists, psychiatrists at each of these organizations who were going to be the leaders of the mental health teams or on the front lines themselves. And we wanted them to know what that score meant or have a feel for that. And if they used a measure that was an old friend, they would be a lot more comfortable with, we thought, or we hoped, than if it was a newfangled measure or a measure that they didn't have as much familiarity with. So one thing is we initially thought about using measures that had sort of a greater span from sort of wellness to having a lot of symptoms. But we ultimately decided to go with, again, these tried and true measures. And I think that that's been a good decision just in terms of hearing feedback from the mental health teams and seeing how many people are symptomatic. There's a lot of people in the symptomatic range, and particularly with our users, the people who adopt the app and are using the app are people for whom mental health is largely more of a struggle.
We're struggling. Yeah, who are kind of on that borderline between stress to actually tipping over into distress.
Right.
So PHQ-9, it was GAD-7, you had some trauma measures, and we had a simple sleep questionnaire as well, acknowledging
right.
that
Yep.
self-report on sleep's not as good as measuring it more objectively. And the change we made was that we're asking it weekly rather than only every 2 weeks, just because it's changing so much. And that was, again, a trade-off. Like, ideally, you'd ask people daily how they are, but that's too much burden with these people who are incredibly busy already, right? So in the end, we said, okay, how can we make it so simple that they could literally fill in the app on their way from the hospital through the car park to their car? And that's why it became these sort of simple questionnaires.
Yeah, that's right. I think the ideal might be to ask, well, and it's hard to know what the ideal is, but it might be to ask them based on their responses, and stretch it out longer if they're doing well, and ask it sooner if they're less well. It's something we don't have programmed in, but that we see, 5 minutes a week. It's pretty quick. People have been, our retention has been good so far, but it's definitely, again, early in the process, and we're just gonna have to see.
Yeah. And then a key difference is, like, often when people fill in those surveys, they don't get to see the results. And we made a decision right from the beginning that we actually that we show them the results. So actually, Yuchi is one of the engineers in my team who built all those reports, because the tool we were using is a Google Cloud tool that didn't support that kind of reporting back to the end user. But we felt that was really important, that it was about self-measurement as well as connecting people to resources and identifying people who needed help.
Yuchi is just an amazing problem solver. So thank you so much, my friend, for your incredible talents and lending him to this project.
So Kelly, can I jump in with my question? It's Kimberly Klaus. So I'm calling you from Brookline, and I live very close to the Boston Medical Center. Like it's walking distance, and a real oh, here comes my family. A real pivotal point for me in COVID was seeing tents in my neighbors' front yards, because it was, the medical workers, right, the physicians, coming home, right, sleeping in a tent, not wanting to infect their family, and that was just a very striking, sight to see. But one of my questions is, the issue of physician burnout has been, has been known for years, right? There's been a lot of research around just physician burnout in general. And I'm sure that applies to other people in the healthcare field. So it seems to me like with so many other things that COVID has accelerated a trend that was already in place. And we're seeing that, you know, a lot of different areas. What do you think like systemically needs to change? I know this is a really big question, but it seems like, you know, the mental health of healthcare professionals has been an issue
Right.
for a while that's becoming more acute in the current environment.
It's a great question. I think that I think that the general wellness space, this has, and heaven knows should, accelerate organizations attacking that issue. And as you know, there's been a lot written about the easy things that people have tended to do is say like, oh, well, you know, go off and do like yoga or do like whatever, just kind of put it on the individual rather than say, oh, how can we tackle these organizational issues that are contributing to this and that are important contributors to this, but that require real organizational change and not just, you know, giving someone a half-day seminar or offering them some support tools. And no disrespect on those, but I think the harder things are the organizational. And so I think that there's hopefully more of a mindset to address those and attack those. But I think you're exactly right that it has really accelerated the challenges in general. I do think that people find it very, well, speaking personally, and I think for many, it's incredibly satisfying to be a physician during COVID, because people who have COVID are, and you know, certainly this is true for me as well, it's scary. And so, and it's almost like, you know, if you said, well, you have pneumonia, like 5 years ago, like pneumonia, and obviously everybody based on their life experience, friends, whatever, they might, but if you're bad, that might be scary, but COVID obviously carries a particular, because it's been so spoken about. So anyway.
You didn't talk about your experience of getting COVID. So this was something that actually happened right in the middle of the project, where Sam stopped responding to my emails. And I thought, oh dear.
That's
what
right.
is happening?
No, it's so true. It's yeah, it was only like a couple weeks after we started that I got sick, and I was fortunately only like really sick, like gosh, I don't know, maybe a week, 10 days, maybe like a week. I was really, and so I was very fortunate, but it was very scary. It was very scary to have my family infected, and so yeah, it was just a strange time.
You came back with like even more resolve. Like that's what I remember.
Yeah, no,
like,
for sure.
I'm back, and now we're really going to make this thing happen. So.
Yeah, absolutely, yeah. Yeah, it's true.
We were going to go to Hope next.
Yeah, hi, I'm happy to be here. I have a question that kind of seems a little bit off topic because it's so broad, even broader than Kimberly's question, which was, you know, I started immediately thinking about applications for this kind of service for, you know, my question, what I called more slow drip kinds of trauma rather than incidental trauma, like, you know, severe poverty and homelessness, and I think, you know, international refugees, and how, you know, like Kimberly said, not only COVID is making maybe some of those things worse, but also climate change and more long-term things. So I'm just wondering about your thoughts in general about the applicability. I was also was thinking about first responders, you know, in this, I'm in California where there've been the severe wildfires too. Anyway, just thinking.
Yeah, no, I agree. I think this general, you know, I'd be actually curious to see if I could pitch that over to Obi, because I think Obi has thought so much about the use of tech and the use of measuring mental health in various settings. What do you think, Obi?
So I think one of the interesting things about mental health is that it changes over time. So it's almost this right now we have this way of looking at it as a snapshot. Like whenever somebody happens to be assessed, they show up at a doctor's office and the primary care physician thinks, oh, something might be off, or, you know, in a refugee camp, they actually do some assessments and so on. But I think you're absolutely right, is that it moves slowly over time. If like an acute trauma happens, it can shift people quite rapidly from one state into the other. You know, you can fall off a cliff. But if it's slow moving, like my life is just tough all the time, it moves more slowly, and that actually makes it even harder for the individual to know when they need help and when is their life just stressful and when is their life like becoming unbearable. So that's why I think partly we need more objective measures, because it's very hard for yourself to know when your state is changing. So I think we need better measurement of mental health in general. And we need more of these longitudinal measures. Now, the trouble is, like we talked about the burden when we talked about these healthcare workers, right? Like nobody wants to fill in surveys all the time about their mental health. And I don't think it's so much the concern that it makes you worse. So that has been studied. Like, you know, if you're filling in a survey about your mental health, are you drawing more attention to it and therefore you get worse? I don't think that's the biggest concern, but it's a hassle. And it's not something you want to be doing all the time. So if we can find more lightweight, more passive ways of tracking people, then we could actually do it more at a population level, and we could do more preventative care. So not wait until someone is in crisis to intervene, but actually kind of catch them earlier, because then you can avert some of these more severe cases. But we're a long way away from that. I mean, we're generally a long way away from preventative medicine in all kinds of medicine. And I would say mental health as a field is way behind. I mean, diabetes is a really good comparison, I think, Kelly, right? Where people used to die only a few decades ago because you couldn't measure blood glucose. And then that was the huge breakthrough, that there was a single biomarker that suddenly allowed people to track their blood glucose and make adjustments to their diet, to their insulin regime, to their exercise, etc. And it's completely transformed, you know, people's lives. Like you're perfectly functioning with diabetes. And so my vision is that we'll get there with depression and anxiety, that yes, it might be something you have to manage, but you can function even if at some point you had a diagnosis. But the only way we can do that is if we can measure ourselves. Unfortunately, there isn't a simple single biomarker. There's no one thing like blood glucose that we can measure about depression and anxiety. It's a sort of complicated, tangled web of multiple influences. So we can get at it with multiple angles, like sleep, like activity, like location, like Sam mentioned. You know, if I'm not leaving my flat, suddenly probably something's wrong, right? Except lockdown. So there was a bunch of these digital phenotyping studies that were studying location. And then of course, all of that ground to a halt when lockdown happened, and everyone was suddenly, like the location signal was suddenly no longer so useful, right?
Yeah.
But the deep signal still was.
It's interesting though, I think, because it's that piece of, should we work more on prevention or should we work more on treatment? And patient-reported outcomes are also very controversial and not at all standardized in diabetes. And you're right. I mean, CGM, which Alphabet now is helping bring to everyone. This monitoring is so much easier, but it doesn't actually mean that the long-term outcomes aren't as bad. It's like they're not as emergent. Like people don't die as much of like ketoacidosis, which is when your blood sugar is way too high. But it has changed things dramatically on like hypoglycemia. You have made it. You have helped Dexcom and Abbott and Senseonics and Medtronic completely change this. But it is interesting. What if you just didn't have it? So if you just didn't have hypoglycemia, and what could we change about the hospital environment? And Sam, I'm so interested like in that piece, because I completely hear what you're saying about COVID and how stressful and how anxiety producing, and what else in the hospital environment is really stressful and anxiety producing that doesn't need to be as much. And are people thinking more about that? Yeah, do you think are you also capturing that?
Yeah.
And how are the hospitals responding? I mean, I think it's so cool that UNC was like, yeah, let's do it here. But like, how are they feeling about the responses? Sometimes it's, be careful what you ask for.
No, that's right. Yeah, that's right. I think that people know the concept that there's a ton of burnout is very sort of well accepted, and there's an understanding that that's everywhere. So I don't think that so much concerns them. I do think that, for example, if COVID was not going on, that just the medical legal departments would put the kibosh on this at so many of the medical centers, just because, like, well, if we don't know about it, well, we can't get in trouble for it. But, you know, and unfortunately, you know, I think it's fine for legal to weigh in. It's their job as the legal department, but there has to be someone who looks at the greater good and takes that as one input. And again, I think fortunately we've seen that at, you know, many places, and continue to do so. So, well, you know, which is heartening. But I think that it's a very interesting time with you know, what's going to be the response. I think a big challenge has been that all the medical centers in the United States are doing very poorly financially this year, because COVID has really cut back on elective procedures. So many procedures and things that honestly are kind of more the money makers for hospitals and health systems, and then they operate on such a thin margin. So in an area, at the same time that there's a huge stress, you know, psychologically on people, there's also a lot of financial stress. So that, for example, private practice emergency physicians, say, in some groups, will see their salary go down this year, sort of 40% or 50%, simply that I think probably, I would say maybe 20-30. And so what that means is that the hospital is also dealing with less resources right now. But again, I do think that there's also greater recognition that this is a huge issue that needs to be addressed, and hopefully over the longer term, as resources improve and as COVID evolves, that will have hopefully a more lasting effect.
Yeah,
Right.
I'd love to come back to this, but Obi, if you have any comments on this, it's great. I'd love to circle back with it afterwards, but I want to make sure we go to Rio, I think is next. But that's really interesting, Sam. I mean, we're really getting at, like, why do hospitals exist, and, you know, like, what are you imagining hospitals being like at their best? You know, but very right to acknowledge.
And in general, as you all know, I'll just say, you know, the whole healthcare system, no secret, is a complete disaster. And so, like, you know, so that is a minor, like, you know, wrinkle in the background. It's just like the whole way that people are paid. It just is all just so wacky. So we'll see if anything changes on that.
Mm-hmm. Yes, great. Rio, we'd love to hear your question.
Hi. Okay, so I apparently have an unstable connection, so there may be some cutting off. But my question, I have so many questions, but I think the question that I put in here was about, so you mentioned the short survey, the short questionnaire that you do when participants sign on. How do you assess what level of care is needed? Like, what are the thresholds? And also, do you do any quality of life measures? And would it be helpful to take a baseline? Do you see doing that in the future, taking a baseline first?
Yeah, it's a great.
Would it be helpful to have a quality of life measure?
Yeah, that's a great question. So we do ask some questions. We do ask a few questions about in this very brief survey about sort of interference with function and mental health function. But our goal, what makes it easier in this setting, is that our goal is really just to identify low, medium, high symptoms, so that then a mental health professional can do outreach. And we want to get a lot more connections and touches, ideally between organizations and the healthcare workers, whether that's environmental services folks or, you know, whomever. And again, the sense is that, I don't know about you guys, but the last time that someone called me from my work, from UNC, and was like, "Hey, Sam, just want to let you know, you're doing a great job. Really appreciate you. Really appreciate what you're doing. Okay, take care." You know, it's just like, it's not like a daily occurrence for people. And so if we could get people a general sense of how folks were doing, identify people who were in, kind of in the vicinity of potentially needing some support of some kind. And then get them connected and get outreaches performed then, and really increase these numbers of touches between the folks who are mental health experts in an organization and the workers, that would be a win. So you're absolutely right. Those are fantastic issues. They're a little less of a challenge for us, simply because then we have outreach by a mental health professional based on the symptoms that can do an assessment conversation, sort of see what the person's interested in, what they might be willing to do, interested in doing, and also sort of follow up on all those issues.
Right, and one of the reasons we picked no, Rio.
Just one more quick question on. Sorry, I know it's a program that has only been in operation for so long. How do you plan on measuring success, the efficacy of the program?
Yeah,
what are the measures you'll be using?
That's a great question. We really are interested in looking at all of the mental health outreach to individuals, and then what mental health outreach they got. So they received. So we're not doing an in-depth. We're going to look at their mental health over time, of course, as recorded by their surveys. But we also want to know, like, okay, of all the people who are called, and people who are reached of different types of symptom levels, what are they connected to? Were they connected to a therapist and started getting treatments? Were they offered support and a recommendation of an app? But we want to know what are these outcomes of all these calls? And so that's sort of our first step. But I think there's a lot of different things too. How many people use the app? How many people continue to use the app? So sort of it's a variety of different measures, and it's a great question.
Kimberly was talking about burnout before. Do you think, what's the bridge to thinking about wellness and about how well healthcare workers can be?
Yeah, I'd say I because we're kind of in the middle of this COVID crisis, like I said, I think that it's really important. I think people are recognizing that we need to address and go deeper into the causes of wellness. There's certainly, and I would say there's more advocates for that, for going deeper into the issues that are drivers of mental health or reduced mental health in the area. I do think that because we're still very much in crisis mode, that it is not as much of a, I think there's a recognition that we need to do a lot more. And at the same time, people are trying to get through the day and get through, get through the week. And again, it really depending on where they are. Like, if you're in North Dakota this week, or if you're in, areas of Utah, or, just there are places where they're completely overwhelmed. Or even within our state, we have hospitals, within our 11 hospital system at UNC, we have hospitals that have relatively little COVID, and we have hospitals where 40-50% of the inpatients are COVID, and they have a difficulty getting someone admitted. So, because there are hot spots, and so it's really, it so varies by that. I think, for just as like an example, I think that, when somebody is really, even as an emergency physician where we see sick people, you don't often see people where you wonder what happened to them. Like, how did they do? Like, if you see someone who's very sick, or you think is becoming very sick, you think about them just like any physician or healthcare worker would, or anybody would. And then you follow up with them, and you follow up on how they're doing. And when you see lots of people that you took care of that then subsequently died, or had a bad outcome, it's sad, and it's very difficult. It's difficult to experience that. It's difficult to, you remember them. You remember the people. I remember conversations I've had with people who were getting sick with COVID, who did not survive their illness, and you remember those people. They stay with you, and it's difficult. And so it's that kind of thing which really burdens healthcare workers right now so much. It's all the people that you remember, that you had conversations with, that you saw, that you thought about, that you think about. And so people are dealing with that, and so many places in the US right now, and it's very hard.
Yeah, Kimberly has another amazing question. Kimberly, sending it over to you.
Oh, great, thank you. So how can we support our healthcare workers? You know, for people who, I mean, I'm just so appreciative of, you know, the extraordinary work that people are doing. You know, one thing that some restaurants here are doing, and I'm sure that this is happening in other cities, is you can actually, you know, call a restaurant and have takeout delivered to healthcare workers just as a thank you.
Yeah, that's I think I think that's really nice. I think any expression of appreciation or thanks, you know, to someone you know, and this is true, of course. Again, I don't mean
Even
I'm
someone you don't
sensitive.
know, right?
I'm sensitive to the fact that, you know, there's a lot of essential workers who are working out there and and putting themselves you know, in different ways, but certainly healthcare workers are. And again, I think like the biggest heroes to me are the environmental services workers who have the least socioeconomic advantage, have the lowest salary, and are still, you know, going in every day and or like our clerk. I remember our clerk and we have so many great clerks, but one clerk in particular that I really like a lot is an older guy. And when COVID first started, he was like, you know, he's kind of semi-retired and he does the clerk thing as a second job, and he didn't have to be there. You could see him really kind of struggling with that, but he's totally seen it out and he's still there. And he's got this really long hair because he says he's not going to get a haircut until COVID ends, you know, and he hasn't had it like done a home cut. And he's just gonna, but he's like, he's gotten used to it and he's settled in. But I mean, there were so many people struggling with that. Like, you know, I'm 65, I'm dedicated to my job, I'm part of a team, but I don't have to be doing this. And it varies, but I think the environmental services workers work really long hours for really low pay. Those folks deserve, you know, I personally would say, you know, call up a local hospital and say, hey, where can I send a basket to the environmental services worker room, and say thank you so much, or send some donuts, or send some whatever, anything, and say, you know, thanks so much for what you're doing for COVID. I think that's really nice. And I think, again, I would say environmental services workers because I think that people don't think about them as much. And
well, actually, I don't really know what environmental services workers do.
I'm
in
sorry.
hospitals.
These are the people who like, so basically we have all these COVID rooms and they all have to get completely decontaminated and cleaned down before the.
Okay.
So it's basically like the janitors, you know, janitorial. I mean, it's much more than that, and that's no longer a term, but like to use it more, you know. So anyway, and we have fantastic environmental services folks who go in but they're cleaning all these COVID rooms. They have to put the full PPE on. They're cleaning everything off, and they're, you know, in terms of just like being surrounded by virus, they're surrounded by virus because they're cleaning these rooms where people have been really sick with COVID. So. Yeah, and so, you know, just sending them and we've been advertising them for our app, and we do a lot of flyers with them. They tend not to check email as much. A lot of immigrants, a lot of people who are getting a foothold in the country, and but just fantastic folks.
Okay, thank you.
Yeah,
it's a great suggestion.
I was just wondering, Sam, if you could also talk a bit about your background is so interesting, you know, like how did you get into so there's the like emergency room piece and the anesthesiology, and then there's this whole, I don't know how you know.
I know, I feel like I spend just little enough time in any area that no one can get like sick of me, or what's that's the Groucho Marx quote. I would never be a member of any club or organization that would be willing to have me as a member. So I'm like a member I'm a member of a number of different ones. I did first I did an internal medicine residency at Mass General, and then I did a emergency medicine residency at Boston City Hospital, Boston Medical Center, and I became interested in looking at longitudinal outcomes after trauma, really for I sort of fell into it for a variety of reasons that were somewhat happenstance, somewhat interest, but I just was fascinated by the neurobiology and by mental health outcomes, and I've always been fascinated by that. Like I think so many of us, just about you know, what makes us all tick, I think is a common interest, and so I've been very fortunate to be able to do research in this, you know, really interesting area.
And so then what happened? So how did you have the idea? Like, did you, for the app, did you wake up one night?
Oh,
and-
I just asked Obi if she could maybe make an app, whip up an app that would allow like somehow the mental health workers at an institution to do outreach to people who were having mental health symptoms, and just was extremely fortunate when she said yes. And she is a real thought leader in this space and had taught me a
I would
lot.
love to, yeah, and I know I should have talked about that. Obi, can you say a little bit about that, and what was your reaction? What was your reaction when Sam contacted you? It sounds like Google X might have been working with UNC already. I don't know anything that you could say, but yeah, we'd love to know more.
Right. So I was very fortunate in that I said yes, but and some of the engineers on my team immediately said yes and said we would volunteer and help to build the app, but we needed a platform, and that's what Google Cloud provided. So they actually have a product that's in beta that enables researchers to run real world studies on mobile, and it's based on a idea that the FDA had called My Studies to do more mobile-based studies. And so it's that kind of real-world evidence platform that we trialed. So they haven't launched the project officially yet. And so Heroes Health became like a beta client for it. The product manager, Jamie Rogers, and the cloud team loved it because he got all this feedback. Because both the volunteer engineers inside Alphabet, as well as like some engineers that he was working with in India, as well as like UNC's team, like Sam's team, the IT team that you brought in over on the UNC side, basically gave him lots of feedback. And we built the first instance, but then we handed it all over to UNC. And that's something I should have mentioned. So Google doesn't have any access to the data. It's just running on the cloud platform, and UNC is really in control of the app and also making updates and any changes. So that was very important to us, was that the privacy was completely preserved, but also that UNC would have complete control of future versions of the app. So we sort of took it to the pilot stage, and then we handed over.
Yeah, I wish more, I'm so sorry to interrupt, Obi.
No, go ahead.
I was just going to say, I wish more people, especially investors, Alphabet and people watching Verily so closely and all of that would know even more about this. I mean, it's stunning to think of how your team responded, and also that Alphabet was really like, let's go. That's
great. It was a wonderful partnership.
It was very volunteer-led. I think that's actually one of the amazing things, is that engineers just across the entire organization just said they would contribute their time. So they did it sometimes in their evenings and their weekends, etc. So it wasn't sort of like, we didn't wait to ask anyone for permission. We just started working on it. And it came together very organically, which was amazing. And getting all that help and support, I mean, you give me way too much credit, Sam, but it really was this sort of volunteer force across the company that did it.
Yeah, well, I can see
great questions popping up.
People were so moved. Yeah, Frank, I'm going to hand it over to you next.
Hi, thanks Obi and Sam for sharing this great development. So I had two questions. One is, I know you touched on this a little bit, and forgive me if you already mentioned this while I was cut off after the Zoom bombing, but how do you think about developing interventions in the app, either through like a therapist assisted chat or some other kind of module, or completely free of any therapist intervention that can potentially reduce the worker's barrier to getting mental health care, since it often takes a lot of effort to actually set up an appointment, find the right resources and so on. And then related to that question, for both of you, I'm sure you are aware of many mental health focused apps that have been in the market, and I'm aware that this is not app that's made to go to market and compete necessarily, but I'm wondering, as you were going through this development process, what are some things that make the Heroes Health app unique compared to what's already out there? And this is something that I'm sure you've thought about a lot as you're thinking about developing it specifically for frontline workers.
Yeah, it's a great question. So the first question is also, they're both fantastic questions. I think in terms of the digital health intervention sort of space, I think that you're exactly right that we think of it just is in so many areas. I guess it's kind of a pick your area type thing, but it's certainly for among healthcare workers, if we could identify digital health interventions that were effective, there's so much more lower cost can be done by the worker on their schedule and on their time, and you could potentially have a lot greater reach into sort of the healthcare worker workforce. And so, and then how exactly one would do that? Again, we have sort of been looking for funds to try sort of two different approaches, but we don't really know because it's early days. But one idea is that, well, maybe you could give people a survey and give them an initial assessment and learn about them and sort of their background, mental health interests, and then match them to what the best intervention would be for them. So for example, if we say sort of the maybe arguably sort of the foremost common types of interventions you might say mindfulness, group interventions, and then CBT, and of course group can be CBT or non-CBT, but maybe say a group therapy with a CBT bent versus individual CBT that is either tech supported or individual supported, and then maybe mindfulness interventions. So we'll just take those for example, and say like, can I get an assessment that's better than just having someone pick their own? Or if I say that's a question that we don't know, certainly if I just said, oh, just read about these and pick which one you thought was best for you, is that fine? Or is there any additional utility that I can gain by saying, okay, Sam, do this initial half-hour survey, and then based on your survey responses, we're going to tell you what we think might work best for you, and we want you to try that, if you're willing. So I think those are kind of questions that we'd like to be able to assess, and additional support that we'd like to be able to try to fold into the app. We do, because we're a nonprofit and it's all open source code, as Obi said, we have an advantage of not building one particular app and then really marketing that app. So we can go to third parties that have done expert assessments of apps and say which one would they think work best or the lowest cost best, and we could be sort of a way to get those to people. So what's the best in class of mindfulness, best in class of, or one of the best in class of a particular type, and then be a conduit to connecting an individual with that. I think there's a general space for that. And the great thing about this is that we're really, there's a lot to test and learn, and it's really a process of just trying to figure that out. And then I think your second question was about Heroes Health and what it provides that others don't. I think that I really saw this as a way, as I mentioned initially. So it's a number of different things, because we also want to serve the individual healthcare worker potentially who's in the middle of nowhere, quote unquote, and who doesn't have an organization to kind of connect through, or an organization supporting the app. But I would say that the first, maybe the sort of the goal is, or maybe the focus is the connecting through organizations. And we didn't know of any apps that were sort of healthcare organization based, and that were about connecting mental health resources within an organization to healthcare workers. And so we saw that as an opportunity to do something useful during this time, we hoped.
I mean, it's a great question, Frank. And ultimately, we need to get to a place where you can measure yourself, and then you can be connected to the right help at the right time, right? So answering that question of who needs what kind of care when, is not really answered in mental health very well today. And if you can integrate that into one platform, it'd be very powerful, because there are a number of digital interventions that are standalone apps. And then you've got a few measurement tools, but the measurement tools tended to be either very simplistic, like a mood tracking app that is so basic that it doesn't really connect very well to the interventions, or it was these scales and these surveys that were really designed for clinicians. So what I love about Heroes Health is that it sort of uses those scales, but it flips it and puts the emphasis much more on the healthcare worker than on the person treating them. And that shift of perspective, I think, is quite profound. And that hasn't really happened in mental health. So if it flips from something that you are more in control of, where you're collecting your own data and then using that data to make decisions about your own life, including when to reach out for help, like when you might need third-party support or when you might need to do self-care, like meditation, then it's much more empowering to the individual. And that flip, I think, hasn't really happened. That, I would argue, has happened more in diabetes, for instance, of like enabling people to do their own thing. And that kind of platform that connects the two doesn't exist yet. But the measurement tools are starting to emerge that would allow us to do that at scale. And then on the flip side, the digital interventions are starting to be more validated. Like a lot of the apps, unfortunately, today haven't gone through that sort of rigorous validation yet, but it's happening. So just Headspace, for instance, is running about 70 different clinical studies on the impact of meditation on depression and anxiety.
Wow.
So as you see those studies coming through, you know, these interventions are being validated and then will also hopefully be deployed more in that setting. But what you described is like the holy grail, right? It's like I measure myself and I get connected immediately to the resources that I need. So one day maybe we'll be there. We're just not there yet today.
Yeah, and it's so interesting even to think about, you know, that you could learn who needs to meditate, and that would also help propel everyone to, what if everyone learned how to meditate? Just like this is just competency about how to take care of ourselves, and it's taught like math. So I guess that goes back to the discussion about prevention. Sam, I know it's getting really late on the East Coast, so we cannot thank you and Obi enough for this incredibly absorbing conversation. We would also just love to know, maybe the last question, just about how would you best like people to spread the word? I think so many of us want to spread the word among healthcare providers. Can you talk about who's funding this, you know, how the funding is based, and if people can help on that front, or what you're most looking for and how we can most help to spread the word? We're blown away, and gosh, thank you so much. We can't wait to get this recording together.
Well, that's very kind of you. So thanks so much again for having me. It's been a real pleasure. We are very fortunate to be supported by a number of foundations, Rockefeller Foundation, Bank of America Foundation, and have raised several $100,000 that are to support, or actually more than $500,000 now to support the initiative and the startup and the spread. Our focus right now is trying to enhance the app to be able to serve folks better through the digital intervention, and trying to roll out, as I said, trying to figure out what we can put together with the funds that we have, just to be able to further support workers through the digital health intervention and add that piece to the app. So certainly if you have any suggestions about foundations or supporters that we might apply to further funds to do that, or if anyone has those, that would be fantastic. And yeah, otherwise just spread the word about the Heroes Health app. There are, we do have the Heroes Health webpage. We have a webpage through UNC where one can give if one likes, but yeah, spreading the word and sharing with people. And as I said, you know, calling up and thanking an environmental services worker or someone that you see, that's a wonderful thing.
Wonderful.
And it's not so much me who knows who that would be, but definitely people in our community, and we're going to be spreading the recording everywhere. And and talking to so many different hospitals as well about the power of this. I'm so moved, as I know everyone is.
No, well, thank you so much. And again, it's just been so much fun to link up and have a chance to have this wonderful conversation. And again, none of this would have happened without Obi, and she's an incredible leader. And I've been so fortunate to become friends with her in the process, but also just have this fantastic partnership. So huge thanks to Obi and Axe and everybody at Alphabet as well. And as I said, I see Yuchi still here, all of these amazing folks that made this happen.
Well, thank you for starting it. It would definitely not have happened without your perseverance, Sam. I think I would love to just close on a sort of positive note. Like, COVID is causing all this misery, including more mental health issues. The numbers have gone up in the general population as well, not just among healthcare workers. So what I wonder is, like, what are the positive things that we can take out of this? And one of them we talked about already is stigma, is particularly healthcare workers just never talked about their mental health, right? Partly because of fears that they thought I might get struck off, or like suspended from work if I'm admitting that I'm struggling, because burnout is something that can interfere with your ability to make decisions and so on. But now, because it's so widespread, everyone is experiencing anxiety. It seems to have made it just much more acceptable to talk about that. And I really hope that that's something that we'll take out of this crisis, is that people are more comfortable with talking about when they're struggling and more comfortable with reaching out and getting help. And then the other piece is that things have moved incredibly quickly towards digital. So part of that was the FDA lifting, for instance, telemedicine restrictions. And telemedicine peaked for all visits and then kind of went back down for a lot of the physical visits, which are back in physical doctor's offices now. But telemedicine has stayed pretty high for mental health. So it's still at about 70% of all visits to therapists and psychiatrists and so on are through digital means. And that's another thing that hopefully we will be able to preserve and accelerate. So if this crisis can serve that, if it can accelerate a couple of these trends that had sort of been moving really slowly, I think that would be one of the amazing positives that could come out of this incredible, heartache and misery.
Totally agree.
Yeah, absolutely. Well, my gosh, I mean, everyone join me in sending you so much appreciation and admiration, and lots for us to think about. And this is going to be at many dinner tables and many breakfast tables and lunch tables and all of this. So, well, we just bow our heads, and really what an honor and a privilege this was, that you would come speak with CPS Lectures tonight, Obi and Sam.